Ladies and gentlemen. My name is Suni, a year one full-time MPH student. So it's my great pleasure to be your MC for today's dialogue. Now, a few housekeeping announcements. First, please ensure that your mobile phone is set to silent and please refrain from consuming food inside the lecture theatre. Second, please note that we'll be conducting photography and videography throughout this session, and this session is currently being video recorded. Please also note that mask wearing is optional, but you are strongly encouraged to do so if you are feeling unwell. So for guests who would like to connect to the NUS Wi-Fi network, please follow these steps. Feel free to take a photo of this slide in case you need to refer to the steps later. I'll keep this on for a while for you to take a photo. Okay, if not, distinguished guests, colleagues, and friends, good afternoon, and welcome to a pivotal event that addresses one of the most critical issues of our time, climate change and health. Panel discussions on impacts, adaptation, and mitigation within the health sector. This event is under the NUS Sustainability Connect, which is a 5-week festival that showcases the university's efforts across research and innovation, education, campus operations, and student engagement, and is jointly organized by the Hock School of Public Health and the Center for Sustainable Medicine by the Yong School of Medicine. Climate change, an omnipresent global challenge, has now become the most profound threat to human health. Today, we find ourselves at the crossroads of innovation and necessity, searching for solutions that not only safeguard our health but also protect our precious environment. Our distinguished panel of guests will delve into the multifaceted dimensions of this issue. They will unravel the intricate tapestry of climate change impact on health, explore the adaptive measures taken by healthcare systems, and chart a course for how the health sector can actively contribute to mitigating climate change through emissions reduction. Without further ado, I invite you to join me in welcoming our first speaker, Dr. Munirul Alam, Senior Scientist at the International Center for Diarrhea Disease Research, Bangladesh. Dr. Munirul, please.
Good afternoon, ladies and gentlemen. This is a great pleasure for me to be here to share with you the experience in Bangladesh in regard to the changing climate and infectious diseases. So, I mean, this picture shows the kind of seriousness of the cholera disease. So, a child having cholera looks like this. I mean, you can imagine almost dead, but not dead. Basically, we can revert by using intravenous fluid or other means to life. So cholera is a very ancient disease, basically. I don't have enough time to talk about all this background. A handbill from the New York City shows the cholera sign, and there is an inscription of be temperate in eating and drinking. So in those days, eating and drinking was kind of, stressed on about avoiding cholera. So no person other than the president, 11th president of the United States, James Polk, who died of cholera. It was cholera morbus in those days. So John Snow, a British scientist, he actually witnessed that the Broad Street pump that was in the center of all the outbreak that was taking place in London in the early days of 1800. So he identified the Broad Street pump as the source of cholera in London city. So Philip Passini, a Italian scientist, he actually isolated Vibrio cholerae in 1854, and later on Robert Koch, actually, who was the one to have discovered cholera etiology of Vibrio cholerae actually. So cholera caused 7 different pandemics. The upper ones are basically classical pandemics, and then there was the beginning of the 7th pandemic in 1961. So the 7th pandemic is the most extensive one we are having. It is ongoing still now. So you can see here the spread of the 7th pandemic, starting from the Celebes island of Indonesia, then to Bangladesh and India in 1963-64, and then to USSR in 1966, North Africa in 1970s, and then to Latin America in 1991. So this is the modern genome-based kind of phylogenetic study that shows 3 different waves of the cholera spread. So in Bangladesh, cholera occurs seasonally, making 2 different peaks, fall peak and the spring peak. So for unknown reason, basically the cholera occurs making 2 different peaks in Bangladesh, as opposed to the single peak pattern that is found all over rest of the world basically. So it was Hippocrates, a Greek physician. He actually pointed fingers to the the temperature and the climate basically. So in his writing, he actually described, this is not quote unquote, but I'm just telling you what, in the first place, to consider whoever wishes to investigate medicine properly should proceed in the first place to consider season of the year and what affects each, and then winds, the hot and the cold, and every weather that persists in local ecosystem should be considered actually. So cholera and other diarrheal diseases are basically tropical disease. As you can see, the tropical, so this red lines indicate the tropical region, basically starting from the tropical line to up to 25 degree north and 25 degrees south. This is the range basically. So you all know about the El Nino and cholera basically. El Nino is something unusual heating of the sea surface, and this was realized by the South American fishermen when they realized that unusual sea surface temperature was related to low catch of fish basically, and that was the time when there was a lot of rainfall, dryness, and then outbreak of cholera basically. So in 1991, when cholera started in Peru from the coastal village basically, that was a time when there was El Nino phenomena going on, and the cholera spread to all over the South America, including Mexico, the Central America. So when cholera started in Peru, it was in January. So then in the following, actually June and July, there was cholera outbreak in Mexico. So I mean, when actually this was the time when the temperature of the sea actually rises to the level that is required for the cholera bacteria to pop up basically. So actually we know about the sea surface temperature and chlorophyll being related to the cholera incidence basically. So you know that in Bangladesh we have drought and flood related to the outbreak of cholera. So flooding and drought. So in Bangladesh we have the sign of the changing climate. As you know that this is a wetland, very big wetland called Cholonbil, and people can hardly recall when the last actually the wetland dried. Actually, the first time in the history, the wetland dried because of no rain, and you can see the cattle are being kind of grazed in the paddy field, which is supposed to be wet, flooded with water, and the paddy field is basically likely to be actually floating on the water. This is the variety of paddy, but the farmers are in dismay, like there is no yield, there is no production. So the low level of water in the river causes seawater to come in. So seawater incursion means salinity in the mainland basically. So you can see here there is flooding and seawater incursion and inundating the mainland, and people are at dismay, losing their house and the paddy field for them to live basically. So there is a, I mean, clear tendency of upsurge of cholera and diarrhea. So the hospitals are usually flooded. I mean, in these days, basically, with heat-related, patients, and the number of cholera patients rose to a level of 1,000 per day. So basically, not all people can come and just take the health benefit from the hospital because of the distance and the communications. But usually, the neighboring people can come and travel to the hospital. So we have the history of 1,000 patients per day in the hospital, which is beyond the capacity. And so you can see the tents in the car parking area to convert it to hospital basically. So you can see there is expansion of the cholera basically. So this beyond the tropical line that I indicated. So this is Argentina. They have reported cholera. Many other African countries have reported cholera, and including there is cholera in Ukraine, which is a very temperate weather. I mean, temperature goes below freezing in the winter time. So I just want to show you the experience in Ukraine, which is undergoing this problem nowadays of war. So you can see in the Azov Sea area, so there is a city named Mariupol. So this city had cholera. This has cholera for a long time, basically mild cholera, persistent cholera. But the Russian medical, doctors, they believe that the cholera travels from Asia to that region every time, because the sea actually the sea is the way that, like, the maritime transport travels from Asia and Africa, carries this. But basically there is a steel industry, the largest in the world. This is known as Azov Steel. Basically, this is now shattered due to this war. The steel industry actually releases millions of barrels of water into the sea, and this sea remains hot even during the snowing winter. So people actually have bath there, and they have their, they swim and they catch fish and just get cholera. So you can imagine the relevance of the temperature to the outbreak of cholera there basically. So Dr. Rita Caldwell, an American scientist, she proposed the plankton association with cholera bacterium, and also the plankton serves as a reservoir in which the cholera bacterium can survive and persist in active, non-viable but non-culturable state. So even after that, basically, it was difficult for us to, claim for sure that the water is the source of the cholera bacteria. So satellite was indicating, satellite data, remote sensing data was indicating the climate relevance of the cholera, and also the sea surface temperature and plankton bloom in the Bay of Bengal as the origin source of cholera basically. But in the mainland, it was difficult to isolate the cholera bacterium. So you can see different places we covered for many years, and it was difficult for us to basically isolate cholera bacteria. We have developed a prediction model of cholera, and we could predict cholera, but that prediction model was challenged because of the lack of isolation of cholera bacterium from water. So this is a paper showing that, like, after analyzing 10,000 water and plankton samples, we were able to isolate only one Vibrio cholerae O1, and O1 was isolated. O1 was isolated from 28 samples, and O139 was isolated from only one sample. So you can imagine this is a serious thing that the critics would say that, like, cholera bacteria actually persist in the human. It is human to human transmission. There is no need for environment to be disseminating the bacteria. So we then took the initiative to go back to the coastal village. We know that it is our study that showed that cholera starts from the coastal village in the Bay of Bengal and then flares into the mainland basically. So we went back to the coastal villages basically, And it was NIH that supported us to carry out this study, taking years together. So these two areas are cholera endemic area. So we traveled there, and every weekly or bi-weekly, we collected samples. It was a tremendous, team effort. You can see a lot of teams who are working, like 5 to 6 universities of US, ICDDRB, University of Dhaka, and other colleagues from different areas. All together, we uh, conducted this study for 5 years, starting from 2004, 3 to up to 2007. So you can see the Vibrio cholerae count is increasing in the Bay of Bengal area. So this is the first time we isolated Vibrio cholerae bacteria in active state. So this is the diarrhea. They're showing the kind of increasing pattern, and also the cholera shows the increasing pattern. Uh, and in recent time, as I mentioned, that in Dhaka hospital we recorded patient 1,000, exceeding 1,000. But during 2022, we had a very massive outbreak of cholera in Dhaka city, in which this is the historical number of like close to 1,500 patient per day. So this was a tremendous shock and blow to the physicians and the administrative people managing the hospital because of this massive outbreak, and handling those many, this many people were is a very big task basically for us. So you can see we just analyzed the bacterium, and we found that basically there was a new clone, that is the BD1, BD1.2. It was previously it was BD2 basically. I show you one example. Like this one is the previous work that we have done. BD1 was the clone that was overtaken by BD2. The BD2 was causing outbreak in Dhaka up to 2018. But after 2018, we have seen that the BD1.2 took over, and this BD1.2 was basically here. Yeah, this is BD2 and this is BD1. So this is BD1 descendant, like BD1.2. So this BD1.2 was basically clustering with the global clade, basically global clade. This is the Bangladeshi clade, the global clade, but not with the Bangladeshi clade. So this is a new strain. So we are now trying to kind of correlate the climate with the change, the emergence of this new clone basically. So this is our work. We have done many work basically. It is difficult to cover everything in such short time basically. So Vibrios actually transmit through drinking water in the household, among the household of the coastal villagers basically. So this was done in Dhaka. So we have proved that basically it is the drinking water that actually transmit the water, the cholera bacteria. So this kind of transmission of cholera bacteria and other bacteria through drinking water causes stunting among the children. This was a piece of study we have done to show that the children suffering from persistent diarrhea or recurrent diarrhea can lead to wasting and growth stunting basically. So the different set of flora is indicated here. The proteobacteria is prominent in the malnourished children. So this is a vicious cycle that many millions of Bangladeshi children are suffering from basically. So we did a piece of work with chlorination of the household drinking water, and we have found that the chlorinated water basically prevented children and human from diarrhea and cholera basically. So this CHOBI 7 trial was designed. This CHOBI 7 means cholera hospital based intervention for 7 days. The 7 days time that the household members are at high risk of cholera, because when a cholera patient comes to the hospital and report to us, we target them, their family, and we reach out to the family and then teach them how to make their water germ free, how to maintain the hygiene, how to wash hands, and this kind of behavioral intervention we provided basically. And these were the hardwares that we provided. Am I running out of time? 3 minutes, okay, I'll finish as soon as possible. So these are the hardwares that we provided: hand washing station, and this one is for preserving their safe water. This is soapy water, and this is chlorine tablets. So after about 1 year, we have seen that the household members receiving intervention, 50% of the diarrhea or cholera could be avoided using this. So this was highlighted by different electronic and news media, This is in Bangla newspaper, one of the renowned newspaper. And this Chobi 7 program was handed over to the government of Bangladesh, the health official, the secretary of the health, and the director general of the CDC, Bangladesh. So we handed over this program tools to the ministry for kind of incorporation in the program. So, but problem is that the chlorine tablet that we used for making the water germ free was basically unavailable, and also there was kind of a reluctance among the respondents to use this. So chlorine water is actually pungent and bad taste, actually smells bad. So this was the reason that we just tried to go for some other means to make their water germ free basically. So this is a piece of work. My colleague at the NUS, like Dr. Jan Boucher and my colleague Tariqul Islam, we were talking about this in the morning, that we are now trying to provide safe water to the household members using the rainwater basically, because the chlorine tablet is not the way, and boiling is sometimes difficult because of the lack of fuel for the poor people. So this is the coastal village, so there is cholera outbreak. So this study is covering everything, including the microbiota and also the cholera incidents and other things. So this is going on now. I think you in the future you will be able to see the outcome. I'm thankful to you for giving me this time. Thank you very much.
Okay. Thank you, Dr. Muniru. Up next, I would like to invite Dr. Zukhairu Naim, Senior Medical Lecturer at the Department of Public Health Medicine, University of Malaysia, Sabah. Dr. Zukhairu, please.
Hi, good afternoon, everyone. Thanks for the invitation, and it's lovely to get connected with all of you in person. Okay. My presentation is more on the impact of the changing climate on infant and young children and their nutrition status in Sabah, Malaysia. I think before I move further, it's good for me to introduce myself. My name is Zul Khairul Naim, and you can call me Naim. I'm a medical doctor by profession, specializing in public health and in environmental health. I obtained my medical degree from University of Science Malaysia in 2009, and my public health degrees from Dundee in 2016. And then I returned back to Malaysia and do my master in science in 2018. And recently I completed my PhD from Manchester University, and then my work is more on pesticide exposure and human health, not related to climate change. And then, I completed my PhD recently. I'm still in my early career researcher stage. I'm served as a head of department for my medical education department because I'm doing my medical education masters as well. And then after I returned from my PhD, I'm become a principal investigator for a few grants. I received grant from Siahun. My research work more on like health education on One Health issues, where we do like community work on the rabies prevention in 2021. And then I also pioneer for the Sabah birth cohort study, where we follow up the pregnant mothers and we look at their exposure, around the exposure, and then we look at their babies, the well-being of the babies. And then this also like ongoing project. And then last year I received grant from UNICEF to do a nutrition project, where we have like a multi-dimension area where we're looking at the climate change, we're looking at the anthropology perspective. And then recently I also received a grant from Siahun again to do AMR project among primary school students in a rural area in Sabah. And then this is my award. I'm recently I received a 40 under 40 Public Catalyst Award from Boston Congress of Public Health. Okay, this is the agenda of the today. I will introduce my team members for this nutrition project, followed by introductions about the climate change and nutrition, a little bit of the method, and then because this is ongoing project, not so much on the result, and then what's the progress, and then the way forward. This is our team members. It involves transdisciplinary. As for me, from environmental epidemiology, we have people from nutrition, emergency physician, looking at this admission due to malnutrition, and we have a few anthropologists looking at this health from social science side, and then we have like medical anthropologists and a few research assistants for this project. Now we move to the introduction. If you look at this, Intergovernmental Panel of Climate Change has identified 6 threats for the human health, which include like extreme heat, increasing temperature, and also heavy rainfall, and also drought, fire weather, and also because of increase in the sea temperature, it will lead to the reduced food production, especially the seafood. And then this is a little bit busy slide. When, in the ICIPCC assessment report is come up with a few recommendations. What gives me a goosebump is that the choice and the actions implemented in this decade will have impact now and a thousand of years. So in order for us to implement something, we need to have like finding, or we call it a research. So I would say in many developing countries, including in Malaysia, this is what we are still lacking. It's about the research itself. And then in Sabah, for those who don't not really familiar, as Malaysia, we have like West Malaysia and East Malaysia. West Malaysia is the main island. So Sabah in the Borneo side. Climate change is for real, including in Sabah. As we can see that the flash floods is like once in 2 months. It's not just happen in the rural area, but also in Kota Kinabalu itself, in the city area. And then Sabah also like prone area for the earthquake, especially in the Ranau, where you can where the Mount Kinabalu located is, and then heat wave also happening in Sabah. So we know that climate change is happening and give like threats to the human, but not so many people realize that the existing of climate change. So that's why people in Sabah doesn't realize, we are in the climate change era. And then, my presentation is more on the impact of climate change for human and health and nutrition. This is just an overview of it. Climate change, like I mentioned, it will increase the global temperature, rise the sea level, and then the increase the frequency and intensity of extreme weather that leads to various health problem, like Dr. Munir mentioned about cholera, because the increased risk of food and waterborne disease. And then for my presentation, I will focus on the nutrition. For example, when increased sea level, for instance, in Sabah, a majority of them work as farmers, especially people from like urban poor. When the sea level rise, so they cannot go for fishing, so they don't have like money to buy food. That leads to the malnutrition. Um, for example, the climate change. During climate change, for example, flood, the people in the rural area, they cannot go to school, especially for children. So that's lead to like their reduced education among them. And then this figure shows the impact of the climate change for human. And then this more busy slide where we're looking at the impact of the climate change on the children. For example, if sea level rise, and it leads to reduced sanitation, and then increased vector-borne disease. For example, in Sabah, malaria, is everywhere. Same goes to the to the dengue, and then because of reduce of sanitation, it leads to diarrhea disease. For example, cholera, and leads to the nutrition. If we look at this figure, it's not like simple. It's a complex issues, and it involves multi direction. on the left, right, ups, and also bottom. And then because of flood as well, it's in because of flood, it changed the social and economy. The fathers cannot go for work, and then no money lead to food insecurity, and then lead to malnutrition. And then because of the family don't have money, and then increased child labor. And then we can see this if you go to even in Kota Kinabalu itself. Okay, of course, with all these, we talk about the risk to psychological health, and then abuse and everything. And then when we look specifically, risk factor for nutrition is mainly because of food, health, and also the care. So this is three elements. If we look at the climate change indicator, um, if the daily temperature increase, and then we have like extreme temperature, daily precipitation, and also drought, and also increase sea level, it lead to reduced availability of the sufficient, nutritious, and also for the safe food. And then we're looking at the risk factor for the nutrition. It's not just availability, but also the access to get all the SNS, and also food safety, and also food security. That's about food. And then in other arm, it's about maternal and child care. Because of climate change, the mother cannot go to the hospital. Sometimes in the rural area, it's very far. They don't have transport to go there. So what happened to their child, the care of the mother, and also baby. And finally, it's about the diarrhea disease. That is the big chunk of the risk factor for the malnutrition. And we look at the population vulnerable to the undernutrition and climate change. The first thing we talk about demographic age is either young and also old. The first 100 days of the baby life is very important. That will predict their future. That's why in this study we focus on the infant and young children. Of course, if like children, they have more susceptible because of their less immune and everything. And then we look at the biology of health factors. Pregnant mother, for instance, like I mentioned before, because of climate change, they cannot go to get the routine checkup that's lead to various problems, especially the neonatal outcome. Of course, the behavior in Sabah, we have a lot of immigrants from Philippines and also Indonesia. So their cultures is different from Malaysian and from Malaysia. And socioeconomic factor, poverty and marginalized population, because sometimes when they come to Malaysia, they don't have like proper house. Okay, that's why in this study we focus on the infant and young children, especially in the urban area, and the objective mainly looking at the climate of the impact of the climate change and nutritional status, stunting, wasting, and also underweight. So this is the specific objective. So we use ecology and cross sectional, and then this is among urban poor population. So this is I think Borneo, and then we conduct this study in Kota Kinabalu and Tuaran. This is about the method. So we use anthropometry to measure the nutritional status, questionnaire, and for the climate change, we use the meteorology data. Okay, this for the questionnaire. So we ask a few questions, not just social demographic. We ask about food insecurity questionnaire, breastfeeding and complementary feeding, food frequency questionnaire, and behavior and cultural factor. So these are the question in the questionnaire. It's cover wide range. It takes about 10 to 15 minutes to complete this questionnaire. And then for anthropometric measures, so we measure length, height, body weight, MUFA, and also head circumference. And then for the climate change indicator, we look at the daily temperature, extreme temperature, and then about the rainfall and also sea level temperature. So since this project is ongoing, I'll just give you a little bit on the progress. So at this moment, we're able to get 180 infant and young children. It's quite difficult to get them because I mean the range is very short. It's between like 6 months until 24 months, so it's quite difficult, and some more they are very young, so they cry, so it's quite difficult. So this we do at two localities. One is in Kampung Numba, is in the coastal area, mainly immigrant from Filipino, and another one is more structured government apartment in Telipot Ria. And then for the anthropometry, we measure height, length, body weight, and these are the photos during the data collection period. And then for the questionnaire, these are some of the photos. So food frequency question is not easy to ask the mother regarding the diet of the baby. And then the way forward, so we're going continue our data collection end of 2023, and then we will look at this climate change indicator and then analyze of the finding, and then we plan to extend this study where we want to follow up all the babies, and we look at their diarrhea disease, their weight again, and many others factor. And then hopefully this project will give some idea about the climate change and nutrition status, especially among infant and young children. With that, I want to acknowledge the funders from UNICEF, UMS, the team members, all the enumerators, because we need like, when we do data collection, we need like more than 30 enumerators in order to make sure all the data collection will be in progress. Of course, the local volunteers, because it's quite difficult to approach them, because majority of them not are local. We don't know their behavior and also their culture, and of course the study participant. So before I end my presentation, I would like to promote our next event in Kota Kinabalu, Sabah. Is if you are not aware, we have the one society, we call it ISEE, International Society for Environmental Epidemiology. We have the global one based in the US, but this one based in Taiwan for Asian Western Pacific chapter. We collaborate with ISES, Exposure Scientist Asian chapter. We're going to have a conference in Kota Kinabalu, Sabah, in Sutra Harbour on 25th and 26th June next year. And the theme will be circled around climate change as well. I think with that, thank you very much.
Okay. Thank you, Dr. Naim. Up next, I would like to invite Prof. Nick Watts, Director of the Center on Sustainable Medicine by the Yong School of Medicine. Prof. Watts, please.
Thanks, Mike. I might put this down, otherwise I might hurt your eardrums. You can hear me?
Sorry, you have to use this record.
I'm gonna keep it a long way away. Is that okay? I reckon it can pick me up. I'm gonna be brief because the discussion I think will be more interesting than any nonsense I've got to say. And we've already heard from two learned colleagues down in front why this is important. It's pretty damn obvious when you take a look at the slides and what we saw talking about the impacts of climate change on cholera, on malnutrition, on heat, on the spread of vector-borne diseases. You don't want to get alarmist about this stuff, but it starts to feel a little bit terrifying. I don't know enough about that stuff, so I'm not going to talk about it. I'm going to talk about what the hell we're going to do about it. I'm going to talk about the response to climate change, how the health profession, public health, doctors, nurses across the world are responding, and what our responsibilities are, and what it's looked like over the last couple of years, eh? Is that okay? Is that what people were expecting? Fine. If I go over, I need you to go like this, okay? Just kick me off the stage. Globally, healthcare is responsible for 6.5% of total greenhouse gas emissions, healthcare. If healthcare was a singular country, and listen, we're big, so this shouldn't shock you too much. If healthcare was a singular country, we would be the 5th largest emitter in the entire world. We're bigger than all of aviation, all of shipping combined, and we spend an enormous amount of time when we talk about climate change thinking about the emissions from shipping and thinking about the emissions from the flights that we take. Healthcare is bigger than that. The reasons why healthcare should respond are pretty damn obvious when you look at the impacts of climate change. But there are a couple of other reasons as well. If If you look across the world, in Germany, in the United States, the United Kingdom, God forbid, even down in Australia where my accent is from, what you will find is that as healthcare systems have started to run at this problem, and they've only just started, as they've started to, they have realized, number one, it actually saves a little bit of money. Number two, their patients love it. And number three, their staff love it as well. What does it look like when you talk about mitigation, emissions reductions within a healthcare system? It doesn't just look like making sure that you have some LED lights and you maybe turn them off when you leave the room. It is far, far more urgent than that because we've left this far, far too late. To very quickly break it down, you take a look at the buildings that you own, the hospitals, the clinics. That's about 15% of the total emissions of a healthcare system. You take a look at the transport systems. How do you move your staff? How do you move your patients? How do you move the visitors that come and see your patients across the system? That's about 20% of the full emissions profile. It'll vary a little bit, but across the OECD, we think it's about the same. You look at the medicines that the doctors and nurses prescribe, all of the different drugs that we take out in primary care and in a hospital, that's about another 20% as well. You need to deal with all of those emissions there. You need to deal with the 15% that come from the scalpels and the very, very clever imaging techniques, the MRIs and the CAT scans. And you need to deal with the remaining 30% that is the kind of boring stuff, the emissions you find in concrete or in a chair or in the paper that we write on, yeah? You deal with absolutely everything there. You don't just get to deal with 2 or 3 of those problems. I'm going to focus, though, on a couple of myths out there, because I think there are a lot of myths. I think people have a bunch of misconceptions about decarbonization in general and about decarbonization in healthcare, which frankly haven't been tested and are a little bit nonsense. The first myth is that this costs too much money. The first myth is that the reason we can't respond to climate change quickly enough is it's just going to cost too much. The experience we had up in the United Kingdom, where I used to work, is that that's utter nonsense. Number one, we think we can act on the vast majority of the emissions profile of a healthcare system, 78%, without the need for extra cash. It's principally about the clinical decisions we make, where we deliver care, what we choose to prescribe, how we engage with our patients. That's where most of the emissions profile comes from. There is a small uplift. It applies mostly to what you might call fixed and mobile assets, or a hospital and an ambulance. There, you need about a 6% uplift on the capital expenditure that a hospital might normally put in place. Only 6% to meet the full net zero requirement. And the reason it's so cheap is because for the most part, the thing we're talking about is energy efficiency. For the most part, we're talking about electrification of the transport network. Those things pay for themselves. Solar and wind is today cheaper than coal, than oil, than gas. Electric vehicles, 3 years ago, at a global level, new electric vehicles became cheaper than their non-electric counterparts. 2 years from now, we expect that to be true for the average vehicle. In the OECD, and I am principally talking about the OECD, high-income countries here. In high-income countries, an electric vehicle will pay for itself in about 1.5 years. Will pay for that additional uplift. 57% of vehicles sold in high-income countries last month were fully electric. 57%. That transition is happening far, far faster than I think we realized. The myth that it costs too much is simply wrong. The second myth out there is that it's a distraction from the work that clinicians would otherwise do, that our nurses, that our pharmacists, that our physiotherapists have to focus on good quality care, and that this is at odds with good quality care. That's nonsense as well. You can see when you look at the work in Canada focusing on a shift away from low-value care. They reckon 22% of the care provided in Canada is low value. That means it provides either no value to the patient or it actively harms them. Now, not only is it providing no value, it's also damn expensive. If you could cut costs of healthcare in Canada by 20%, and it costs an enormous amount in terms of emissions, and so that's where they're focusing. If you look at the work in Australia where things get a little bit more rural, you got a lot more space to cover, you're starting to see proper investment in telemedicine, starting to say, do we really need to be providing care? Is it really good for our patients to ask them to travel quite that far, or can I provide better care closer to home if I do it remotely? The answer almost always is yes. You have to provide a choice, but it will almost always be better for your patient. It'll be cheaper, it'll be lower carbon. The third myth out there is that our staff are tired. The pandemic has been a rough couple of years and they've got enough on their plate. They don't want to have to think again about, sure, you can deal with the lights and sure, you can deal with some solar panels, but they don't want to have to think again about picking the right thing to prescribe or thinking about the right operation to deliver. There's some cool examples from across the world as well. If you go and poll clinicians in Germany, you will find something that you find also in the United Kingdom, also in France, also in the Philippines. You will find that for Germany specifically, 88% of their health workforce want to work for a healthcare system that is tackling climate change. You will find that number at 78% in the Philippines. You'll find it at 92% in the United Kingdom. This is something that energizes healthcare professionals like nothing else. There's a cool example of a fellowship scheme they've just set up in Colorado in the United States, looking at a lot of this stuff, looking at low carbon medicine. They thought maybe if they got 5 people applying to the first round of the fellowship that they put in place, they would accept 2, and that would be a pretty good place to start, because it's a new field, hey? They had 17,000 applications come in. They had to quadruple the size of what they were expecting. They then had to double it again in year 2 and triple it again in year 3. This energizes healthcare professionals like nothing else. The first myth is that it costs too much. The second myth is that it's a distraction. There's tension between good quality care and low carbon care. Both of those things are nonsense. The third myth is that our staff are tired. It's nonsense too. This energizes healthcare professionals. The final myth that's out there is actually not quite so much of a myth. It's got some nuance. A lot of the time you will hear people say, well, I would go and do something about climate change. I would act on this within my clinical practice. I would act on this at home. But there's not much information out there. There's not enough data out there. This is very, very confusing. It's very complex. How about we run 17 studies first, and then we will think about what we can do? Now, you could do that, but you'll be waiting until 2040, 2050, and at some point, global average temperatures will have passed through their worst case scenario around 3.8, 4.2 degrees. It'll be too late. I reckon it turns out that we have more than enough information to act on the first 1 year, the first 2 years, the first 3 years, maybe even the first 4 years of what we need to do. I reckon healthcare systems can start to run at this, and they are. In the United Kingdom, they have a budget of £780 million a year dedicated to net zero healthcare. In France, just last year, they hired 73 people into their Ministry of Health to tackle this. In Germany, there's a new federal department taking care specifically of low-carbon healthcare. The same in the United States, the same in the states across Australia and New Zealand. This is starting to move at a pace, I think, frankly, that we're not ready for. And that's the nuance. There's more than enough to act in the first year, in the first second year, and in the first 3 years. But very, very quickly, we're going to run out of evidence. And so that is maybe a little bit of what we can talk about at the discussion. And that's what Amanda, who I think is going to come up on stage, is working with me on a new Center for Sustainable Medicine at NUS. The first of its kind. Damn exciting. Genuinely building that road out. Asking the questions of, fine, if the world is going to start running at this, let's make sure they have the evidence. Let's make sure that evidence is clinically relevant. Let's make sure we're not asking epidemiological questions out to 2050, out to 2100. Who cares about 2100? The only thing that matters is what you're going to do at 9 a.m. tomorrow morning. We need to be asking questions and developing the research in a completely different way. to how I think this field has traditionally acted. That's the work we're going to be doing, hopefully making sure that the world has the evidence, that it has the engagement, that it has the cheerleaders it needs to make sure that it's delivering genuinely high quality, low carbon healthcare. Thank you.
Thank you, Prof. Watts, for the powerful speech and sharing. So next will be our Q&A session. I would now like to invite for the speakers, Prof. Watts, Dr. Muniru, Dr. Naim, along with our moderators for the session, Dr. Kimberly Fonace, visiting Senior Research Fellow from the Southwark School of Public Health, and Dr. Amanda Zane, Assistant Dean, Sustainability and Deputy Director for the Center for Sustainable Medicine at the Yong School of Medicine.
Excellent. Well, thank you, everyone. I think we've heard a really nice range of presentations. So I guess just more generally, we've heard a lot of different examples. So about the impacts of climate change, about some of the adaptations, so things like the water treatment that you're doing to address these impacts of climate change. And then as well as how we as a health sector can actually think about how we don't just respond to climate change, but how we actually mitigate it. So what do you see as some of the priorities for the health sector moving forward? So it'd be nice to hear thoughts from any of the speakers. Go ahead, Dr. Nim.
Okay, maybe I look at the Malaysia perspective. Currently, in Malaysia, we also have like a climate change plan. But what I can see that in terms of child-sensitive law and policy is not there yet. They still don't have like child-sensitive law and policy. Because I think this is very important for the children to get like a better quality of health, and that we don't want that the impact of the climate change will leads to will cause the problems to the children. Children have a right to get a better quality of better quality of life. So yeah, that's from my.
Hello. Yeah. So I'm loud enough. Basically, less energy because of the no sleeping at night. Basically. So basically, this is such a problem. Like I have shown you part of the things that is going on. Like the outbreak when starts, like the whole country is like kind of suffering from diarrhea. When there is a fever, like be it dengue or chikungunya or like COVID, the whole country is suffering, and the hospital that we have is very limited in number, so very few people can access the hospital basically. So like just before coming here, I was visiting a hospital because one of my villagers, basically, he was suffering from ailments and he was hospitalized. So in the hospital, I have seen the stream of people actually. There was no room for me to just, climb to the, elevator because so many people are just looking for, access. So it is the situation. Like, think about the coastal villages that I have shown in my presentation. The coastal areas are becoming inundated. The erosion, the incursion of salinity is causing, paddy fields are no longer cultivable. So people are migrating to the city. So city areas are just, hosting them, but with no healthcare facilities, no safe water. The ambience is very, very poor. So these people are always suffering from different infections, different diseases, and one from the other, basically. So this number is increasing every day. So if climate change was a notion, was a assumption, it is no longer an assumption. I have shown you part of the incidents, what is going on in Bangladesh. It's a country, one example. There are many countries in the world who are basically affected already. So this infectious diseases, I cannot just name them, but you can imagine what is not there basically. Everything is there. Everything is like causing problem. So how to solve this problem? Where should I go? I work in an international center which is located in Bangladesh. We have no connection in the government. But we, of course, work for the government, basically, for the people of the whole world, basically. We produce evidence. Like you have seen some of the evidences. So we offer them the evidence to be incorporated in the national program. So it is their kind of discretion to what to be incorporated, what to be done, And also, this changing climate is not only contributed by Bangladesh. Bangladesh is probably one of the least contributor of the climate change, basically. Think about the wealthy countries, basically. The US, the UK, I don't want to name because you'll be hurt. But think about a house. A whole house is air conditioned for one person. I visit US, UK, and other places, Australia. A whole house is air conditioned for one person only. I mean, the whole house is illuminated just for one person. But in my part, like one family needs one bulb. There is no need for air cooler or other things. Just one bulb can just help them for the children to study, the family to kind of do their chores. So this is a combined thing that is needed, basically. So the whole aspect of the changing climate is basically a global phenomena, global thing, and it needs to be addressed globally. No one country can. You have so many questions you can pose, but I don't have the answer. The answer is like the whole world has to agree and come to a point that there will be no emission from tomorrow, and then there will be a kind of a condition. But I'm not skeptical though, but it is very difficult for any country to stop the emission, basically. If it starts, it should be started from today, basically.
On the impact side of things, I think for too long the space has focused genuinely out at the 2050, 2100 mark, and that was important for the phase of work that we were in a decade or two ago. I think it's also sort of tended to focus out at the regional and global level, and that was important back then. Now I think it is far, far more about far nearer term impacts, far more localized impacts. The problem is that we don't have the data for a lot of that because we're relying on some pretty outdated systems there. Unless you're lucky enough to be in parts of North America or Europe, you're sort of in a fair bit of trouble. And so the collection of some of that data as well, rolling your sleeves up and starting to pull some of that together. On the response side of things, we've got to start being more relevant. We've got to start being more realistic. We've got to start being faster. We can't have answers to questions that hospital administrators and policymakers but have the answer 3 years later when the study's published. They need an answer by Friday. And if they don't have an answer by Friday, they're going to make it up and put a best guess in. So you may as well be part of that best guess.
Thanks for that. I have another question. So my name is Amanda, by the way. I'm a pediatrician by training, and I'm at the medical school at the Center for Sustainable Medicine. So I guess hearing especially from Dr. Muniro, about how urgent it feels and how real change already is. There was a regional survey, I think, looking at Southeast Asia, and I think just under half of the survey respondents actually felt that it was a pressing, that climate change was a pressing. What's your personal experience on the ground with this, working with the men on the street and then also with policymakers, people higher up in government?
Basically, the government officials are in the air-conditioned house and air-conditioned office. Their car is air-conditioned, So basically, the people in street, they are in open, there's rickshaw pullers. The rickshaw pulling is such a hard work, basically. They need cold water, but cold water is not available because they don't have air cooler, refrigerator, or other things. So basically, it is very, very easy to say, but difficult to basically implement. So even if we just claim that like this outpouring number of patients that are coming to ICDDRB is one example. Like I have told you about another hospital, a government hospital. So you can just come and see all the hospitals are just like, I mean, overburdened with so many numbers of people. We have never seen this kind of a scenario in the past. So these are all signs of the changing climate. Like people are having dengue, no, there is no hospital access. People are having chikungunya, there is no access. Like I know my driver, my domestic help, my family, my children, everyone suffered from infections. Whatever starts, that never ends. It continues, and then another cycle of infection starts. So these are all the signs of the changing climate, basically. The changing climate is no longer a notion, no longer a hypothesis. This is a reality. So what you are saying, that I mean, we need to work. We need to start working. No nation, including the most wealthy nations, will be spared from this, attack, climate change, impact, basically, because it might take longer. The poor people in the street will die, and then of course the turn will come for everyone, basically. No matter how strong shield you create, I mean, erect around you, is not going to help you. Because you think about the Egyptian, the stony mountains, people used to dig and, you know uh, make them kind of safe inside that. But probably the hot weather didn't allow them to stay there. They had to die, they had to come out, basically. So I think this is the time to, decide what we want to see. We can we can we stop car production in Bangladesh alone? Every day we have 300 to 500 cars added to the street. So the number of car users are increasing. The number of people, using electricity is increasing, basically. The whole country is even if it is a poor country, you know I mean, just elevated to probably lower middle class very soon, middle income country. But the whole country is now illuminated. But think about the amount of electricity required for that. But I mean, if you want to just, you see no emission, maybe Bangladesh can do it, but to what extent we can do it? This is a question, basically. So how to move forward? We should be very, very, very decided, very determined about this. That the wealthy country, those who actually are, contributing to the climate change gases, should be kind of brought to the table to decide, I mean, to bring down the carbon emission as soon as possible. This is what is my plea, and I think every one of us will agree to that.
Okay, yesterday was a heavy rain in Kota Kinabalu, and I can see that the street vendor can open their stall because of the raining, and this is the impact of the climate change. And then because of that, they don't have money. How come they want to feed their family with that? So this example, the impact of the climate change. And in Kota Kinabalu area, there are one islands in the islands has many immigrants from Philippines. If let's say raining season, they cannot bring their sick children, especially for example, if they have like diarrhea disease, they cannot come over, take a boat, because very risky, and then this will lead to complications to the kids. And then based on these scenarios, and what I can say, that the impact is still there, but a majority of I would say in Malaysia, they don't realize all of these are impact of the climate change, and then we need to take action. So this is my personal opinion. And we conducted a survey in one rural area in Sabah, in Kudat, about the climate change, how this climate change impact their food security. Majority of them think that there is no impact of climate change because they can survive if let's say they don't have they need to go to buy fish at the market because they can catch it, or or if they want for example vegetable, they will plant it by their own. So from their perspective, um, the impact of climate change is not there yet. Yeah, so this is my opinion.
I think that there's quite a bit of disconnect when something is so. I suppose because it's so insidious, it's so invisible, it can feel like it's quite difficult for us to connect the dots from the day to day. Are there any questions from the audience at this point for the panelists? There's one from Shika. Hi. I think it's recorded, so they want us to use the microphone.
Okay. So, because we are here, health somehow related to healthcare, the always notion is that healthcare is the business of human lives. And when we try to implement some of the changes regarding to climate, change, so don't do the one project we are doing, right? MDI versus DPI. How strict or how hard should we push it? Because there are still industries who are burning fossil fuel. And if you were to think everything in totality, there are many slices and dices. There are developed country, there are developing country. Who is emitting how much? We don't know. However, we combine entire healthcare, that's 5%, but what about 95%? And the things we should stop or ban would be something like fossil fuel, which is still doing, So we are, I don't know it's comment or question, but it's just lots of thought and questions within my, is always, is that how much should we do? How hard should we do? Are we the one responsible? Obviously at personal level, we all need to have, but if you start thinking of reading newspaper or people driving car or having every aircon in every room compared to, always using or things like that. So it's a difficult, and that related to your question, then when you ran, or there was a survey saying in Southeast Asia, asking that how hard is it climate change? It depends on whom you are asking, or how well or how educated you are. If you're fighting for food and you're going to the, the poorest of poor country where people are just, they don't understand climate change. They just think that why there was a flood and I don't get to catch my fish and, So I'm not saying this is a very elite conversation at right time, but it's just that I don't know. We are in very, at that stage where there are many questions, just questions. We are trying to do our best in our whatever limited capacity, but there are bigger questions and policy related, not even the country level, not even the government official level. It has to go at, I don't know what level, UN level and things like that. So yeah, that's, I don't know, it's a question or comment, but it's just, these are some of the things is there, yeah.
So thank you. Basically, let me share with you some experience. Like I believe myself that think globally but act locally. We have to start ourselves. Like if a light is on, the room is empty, the light should be switched off, the AC should be switched off. I mean, there are a lot of things that you yourself can do basically. So I was witnessing the water loss. Like my neighboring house, they just fill up their tank, but they keep the generator open for the whole night. So there is sound for waterfall. So I always kind of, it's a pain. Like fossil, I mean, the water is fossil water basically. We are withdrawing from underground basically. So the water level is going down and down, down and down. So those people, they don't seem to understand the importance of water loss basically. So I asked the security guard of the house to just tell his owner, master, that tell him that water is wasted. So after a couple of days of inquiring, he then just responded to me. He said that, yes, sir, I told my boss, but he said, don't worry, this is not even, not blood, this is just water. Tell him to not to worry. So this is what the kind of, I mean, people's.
Education also plays a part. In the system when we were studying, there wasn't made, we study in our physics, chemistry, all the fossil fuel and everything. It wasn't made at that point of time. So this concept or this whole thing is not new, but yeah, taking this to the grassroots level is just very far from now.
So
you
this,
and me understand. We do at personal level. Yeah.
so the luxury that we have been adapted to basically needs to be kind of revisited. Like,
Who are this we?
like
Are we paying for urgent this is, and how hard should we push it in healthcare, where there are industries which are totally dependent on fossil fuel, and by law, by policy, they are running. There is nothing big happening. So my question is that when we in healthcare, treating human, I know it is going to backfire to us. There will be no room, and there will be type of patients or malaria patient coming or anything. They will be coming, but
The person involved, the person who takes care of the healthcare sector basically, they come to take medical care in Singapore and Malaysia and in Thailand basically. Go to India, go to US, go to UK. So I mean the poor people, those who are basically, struggling to find a space in the hospital, how do they push? Where do they push? They have so many different problems. Food items are all very expensive. The climate migrants are basically managing to find some space. How do they buy food? I mean, let alone their children, being, admitted to a good school. I mean, there are so many different problems. But above all, the climate is changing, the weather is becoming unbearable, flooding, the drought, everything is like pushing so hard that life is in the kind of crossroad of like people can just stand in front of the gun, and just they can sacrifice themselves. There are people, I mean, they protest, but their voice is not reached to the level. And some people are protesting, but probably they belong to some political party, but they are killed by shooting. What can you do?
You're asking, I won't touch on the international politics element of that, but you're asking a question that gets at the heart of the sort of common but differentiated responsibility politics that runs in around climate change. And it's like a really, really important question that I think we kind of all have to grapple with every day. I got three maybe brief responses. I don't think they're definitive answers because I don't think there is a definitive answer to that question. The first is that in 1990, healthcare globally was responsible for 3.9% of global emissions, and every other sector relative to us has decarbonized. They are starting, emissions are still going up, don't get me wrong, but relative to that, we are accelerating faster than them because we are almost the last end-use economic sector to start to think about this. We're now at about, it depends on who you ask, but about 6.3. You could quickly find a situation where we become 10%, 15%, probably no higher than that, of global emissions. And that's a pretty serious chunk. 15%, you're now talking about just below all of what transport is today, just below all of what the industrial sector is today. I think the second thing I think about is the reason to act on this is multiple. It is partly because of the impacts of climate change. It is partly because it saves money. The reason the NHS is investing so much into this is not because it's a good global citizen. It's because it has a return on investment of 3.6 years. It's because it's just good common business sense. That's why the NHS is putting hundreds of millions of pounds into it. You can do it for the impacts reasons, you can do it for the cash, you can do it because often the response is good for your patients, right? Those are three almost often better reasons than the longer term climate change side of things. Should you ever let those be in tension? I kind of think no. I kind of think we should never let cost, we should never let carbon get in the way of good clinical care, right? At the end of the day, that is where your question started, what we're here to do. I think the final question you asked, my final response is, you can slice this problem up a million different ways. You can slice it up by emissions per continent, emissions per country, emissions per quintile within the economy per country. You could slice it up 7.1 billion different ways by every individual. If you slice it up that way, though, suddenly none of us have any agency, right? And you can intellectually argue yourself into a position of inaction. The best way I think about that, can I just check? If I say the word desflurane, can people put their hands up if they've heard that word before? Desflurane? Okay, some. It's an anesthetic gas. We use it to knock patients out when they need to go for an operation. It's responsible for about 4% of global healthcare emissions by itself, a colossal amount, because one vial of the thing, one bottle of the thing that you use for 1 hour of anesthetic is the equivalent of burning 346 kilograms of coal. It is extremely carbon intensive. It used to be responsible for about 9% of the NHS's emissions. The NHS is now down at the point where we are only using a couple of litres of that every month and is going to get rid of that drug altogether in about 3 months. Everyone talks about desflurane in the low-carbon healthcare setting, and they talk about it in the terms of the hundreds of millions of pounds of contracts and the tons and tons of carbon. But people forget that that story started with an anaesthetist, one person, who asked a question, hey, what is the carbon footprint of isoflurane, a different drug, sevoflurane, a drug before that, total intravenous anesthetic, and then their fourth question, after publishing 3 papers on this, was, and what about the footprint of desflurane? And they realized it was a couple of 100 times higher than all of the other drugs. The equivalent emissions reduction that the NHS will see going from its previous practice to where it will be in 3 months' time is the equivalent emissions of all of the South Island of New Zealand. It is enormous. That's a colossal amount of impact, and we spend too much time thinking about the end point and not thinking enough about Jack and Anita, the 2 anaesthetists at the very, very start back in 1997 that first started that process.
One is that that survey that I mentioned. I don't think it's a concern of an elitist conversation, because I think that survey applies to Singaporeans as well, one of the richest in the regions, and we're roughly about the same. Under half feel that it's something that's urgent and pressing, and it's something that we need to do something about. So I think it's probably a matter of what the social norms are, and I guess moving forwards, what I'm really interested in is how do you tip that social norm, you know, just as how I think how activated people are in the UK and some other parts of the world. I can't remember my second point, but that's pretty much what I wanted to say.
Hi, panelists. Thank you so much for your insightful conversation today. I think the point on actors with the capacity and perhaps obligation to do more and yet facing perhaps more apathy than is warranted for the issue is a very salient one. In Singapore, we had our annual climate rally just this Saturday, and it didn't even make it to the national news. So I guess it did. Okay, not on Sunday, but yeah. My question then is, in the spirit of thinking globally and acting locally, as researchers, how do you make that translation of the significance of the outcomes of your findings, I guess, translating the relevance of it to different stakeholders, even, yeah, on every level? Thank you.
So you probably have, it was faster for me to skip all the slides actually. So fearing the time actually. So I have shown you one slide with the kind of picture showing the national level seminar. I was talking about the climate change and the impact, and it was in Bangla, my own language. So I was talking with with the feeling of my heart basically, to let the nation know that this is a serious thing. You know, the climate is changing and we should be careful about. But for Bangladesh, actually, we don't have much, things to do. Basically, the players are the bigger ones, basically. So this Bangladesh government, ministers, and the electronic and other media, they are taking part in the climate change meetings every year. So I talk to them, and they are basically raising their voice. Even our prime minister, our minister for environment, they also spoke in the different climate, conferences. Maybe the last one was in Paris, maybe, or the last, yeah, Oh, in Egypt. Oh, yeah. The immediate last was is in Egypt. So we have climate experts. They speak very, very loudly. But I mean, this voice should be raised from different corners of the world, basically. Singapore, you are welcome to raise your voice. But we are, from our standing, we are doing everything possible to just make people, understand, what is the impact, long-term impact of the changing climate.
You sure? If the question is about making sure that research is policy relevant, right? I think it's a pretty fundamental question. I've been on both sides. So I hung out at UCL, University College London, in the United Kingdom. I was the Chief Sustainability Officer for the NHS, which is why so many of my examples are from the UK on the sort of policy side, managing that budget I was talking about before. The gulf between what the academics were providing and what the NHS needed was, I mean, I knew it was big, but it was astronomically bigger than I could have imagined. And I'm sort of at the point where thinking most of the incentives that we have in place in academia, most of the ways that we gain promotion, most of the ways that we run through publication, most of the timelines we operate on, right? Thinking about, well, I'll get permission for this study, then I'll get some funding maybe before, maybe after, then I'll do the study, that'll take a year or two, then I'll think about publishing it, that'll take like another 6-9 months to run through that process. And by the time I've sort of published it, 2 years have passed, and the entire problem has either exploded or been dealt with. All of that stuff is fully inadequate. And so I'm sort of at the point where I'm thinking you probably need to run both of those at 2 speed. You need to make sure that you have an arm of what you're doing, an arm of your center or your institute that is fully empowered to take the expertise, take the knowledge, and ignore all of the imperatives of academia. Say, do you know what? That stuff's rubbish. It's important for the long term, and we need to have those core foundations, but we need to be able to draw on those foundations and provide answers by 9 a.m. tomorrow morning quickly. And if we can't, they'll just make it up. I've been in the position where we would ask questions of academics and say, we really need this answer. And they would say, by when? And I would say, oh, at the very latest Friday. And they said, Friday 2027, right? If they can't get it, you'll just have to move on. And so I think you need that track. But don't get me wrong, you can't forget the core foundations of good science. You have to make sure that once you've provided that advice, you've gone back, you've properly verified it. If you got it wrong, you admit it, and you publish that and you build that out. But I think you probably have to think of them as almost 2 completely separate tracks.
From my point of view, so I think we need to do all this kind of research to make sure that they know, and then that also will will enhance the community empowerment because they have that the real result. My expertise is more like on community empowerment and education. I think whatever result from the research we can translate and we can educate based on that, especially for the younger generation, primary school student. Yeah. For example, currently in Malaysia, we don't have like specific module to teach climate change. Even in primary school, we don't have that. So that's why we do research, and later on, we can educate the kids and also the teachers.
Excellent. Thank you, everyone. I think there's been some really good points raised. Just because we have 2 minutes left, I don't know if there's any closing thoughts that anyone wanted to bring up.
What happened in 2022 in Bangladesh, right? That didn't mean that much cholera for, more than a decade. People were like, oh, okay, it's solved, we're good, it's done, And most of the previous cholera outbreak were caused by war or conflict or natural disaster. But this one, pretty convinced it's climate related. But how long is it going to take us to publish the paper to prove that it is? I think it would take Munir and I a couple of years to put that stuff together or more. But it's quite obvious, and I think I agree with Nick. I'm telling everybody this is the first climate-related, massive cholera outbreak, but it is really damn difficult to prove it in a scientific paper. So there's definitely that issue of it's so slow to prove it with all the right stats and everything. But we need to tell people now that it's killing thousands of people, because it's an urgency. Yeah, it's just popped in my mind that these two things were really connected there. Yeah.
Bangladesh experienced temperature of 42 degree, feeling like 46 degrees. Can you imagine? And followed by a record high number of dengue. Like it's still going on actually. We have recorded the highest number of dengues, highest number of deaths. All families are affected, basically. So this is the situation.
Can I? Whole time I was answering the question about policy relevance, a lot of my experience here is in a bunch of countries that are not in Singapore. Can I call on Jason? Because I get the impression that you do, and the work you do at the centre does like a really, really good job of making sure that the core physiology and research you guys are providing is taken up and extremely relevant to work in Singapore and across Asia. Is that right, wrong, and what are you guys doing right?
Partially
too
right.
kind to you?
No. I think the issues that you guys share are very similar to what I'm experiencing too. I mean, back to that comment on why we know that it's a problem, but yet we don't take actions. And I think the rich don't see that issue that is near their door. The poor have other pressing issues, to resolve. I think we need to look back, how we tackle like the smoking campaign, telling individuals that you pay the price downstream doesn't work. Look at our own backyard. We tried many years how to make humans return our tray, and guess what happened eventually? Penalize them. So I think the behavior part, I'm not a behavioral scientist, but I think that behavioral part is important. Don't look at this as a new issue, but then applying the old methods, then we're going rounds again. But because climate change is such a big issue, I'm an optimist, saying that you bring more like-minded, hopefully right-minded individuals, to tackle this. And I kind of agree more that if we keep on projecting issues downstream, it gives the impression that if these problems is happening in a few decades' time. I think while we do that, it's important to effect the solutions almost immediately, tomorrow, 9 a.m. So in my part of work, we just work across the agencies, trying to reinforce that the problem is now, not tomorrow. I think UN Secretary General said it's a boiling world, right? It's not a warming world, in hope that to give another sense of urgency that we are all like the frogs in the boiling pot, right? So it's important we take actions now. So I have nothing to add, but just to reinforce that I agree completely to what you guys just discussed. So thanks very much.
Yeah, I think it's actually very important for us to break down silos, because I feel like a few years ago I would have been completely intimidated by having to talk to any researcher about climate change. But then we've met so many friends here and people from NUHS here in this audience as well. This is exactly the kind of dialogue that we need to have, and have a little bit more tighter collaboration. Yeah. But I think that would probably bring us to the end of this session. But thanks very much, everybody, for actively participating. Kimberly?
Yeah, thank you, everyone. And thanks very much to our speakers. I think it was a really useful set of presentations and discussion. So I believe there are drinks or refreshments outside. So
Yes, so thank you.
I would like to thank the organizers for inviting me. Basically, I'm pleased to be kind of in collaboration with the NUS and working on the population genetics of bibliocolary genomics and the sanitation intervention. So this is going to help basically. So as I said, that think globally and act locally. So we are trying to work. Thank you, Singapore National University, for this initiative.
So a big thank you to all our panelists for the insightful session today. Okay, as they have mentioned, there's some light refreshments outside. We have also come to the end of today's climate change and health panel. So do help yourself with the food and network the distinguished panelists over here. So thank you very much once again for joining us, and we wish you all good health and a good evening. Thank you.